Hello, this is a risk of inheritance of Mendelian disorders presented by the SchrDbb with reference ABC Clinical Genetics by Helen Kingston. So, in this tutorial, we are going to see the probabilities for you in order for you to have a particular allele or transmitting a particular disease allele through your generations. So we are going to have this risk. So we are going to have different examples where we are going to see we are going to calculate the risk for transmitting a particular pathology and all that. So that is it. Now, generally, you need to know that the risk of probability are usually expressed in terms of percentage. That's the introduction point. So the risk for you to transmit one pathologic allele from one generation to another is written either in percentage or fractions, but throughout our exercise we are going to write them in fractions. Is it clear? So we start with the first case. So in order for you to have, so this small diagram here is to show you that in order for you to have any risk, you must start from the pedigree. So you have a consultant, you draw the pedigree of the family. Now, after drawing the pedigree, you have the mode of inheritance. You should know which disease you are talking about. If the consultant come to you, because the consultant don't want to speak about all the diseases of the world, you want to speak about a particular disease, you draw the pedigree and you know the mode of inheritance of that pedigree. So example, if there is a pathology in that that is always recurrent in his family, but you don't know it already, from the pedigree you can know the mode of inheritance of that disease, because you have seen already the tutorials where you see how the pedigree has a pattern of flow with certain Mendelian disorders. Is it clear? Now, from that mode of inheritance, you can also have a consultant who is a prober, meaning that the patient is having a disease and is the one consulting. You can make a diagnosis from then, and when you make a diagnosis from there, you can also know the mode of inheritance of that disease. You can either know the mode of inheritance by the pedigree or from the diagnosis. Now, when you know the mode of inheritance, you can know now the risk of transmitting it to the further generation. So in order for you also to know the risk of transmitting it to the further generation, you can also know the result of the carrier test, because there are certain tests that can help you to know if there is a pathogenic allele inside your gene. Is it clear? So let's start with different examples, like in case of example 1 to 4. So in example 1 to 4, we are just telling you that there are certain diseases that are more expressed at certain age than others. Is it clear? From example 1 to 4, they are just telling you that certain diseases are more expressed from one age to another. So in this example, you have from example 1 to example 4, we are talking about Huntington's disease, and Huntington's disease is a disease that is going to be expressed. Huntington's disease is a disease that is going to be expressed more in adulthood than in childhood and in adolescence. Is it clear? So it means that what? It means that if you don't have the disease, don't have the disease in childhood, it does not mean that you don't have the pathogenic allele. Is it clear? It is only when you have attained adulthood and old adult age that they can, and you don't have the disease, that you can say that the patient actually do not have a pathogenic allele, because Huntington's disease is only going to be expressed it's going to be pathological at the level of old ages. Is it clear? So these are example of cases. So we have example 1. We have example 1 here, a patient having age of 30 years. At the age of 30 years, the risk for you to have a pathogenic allele is 50%. We don't know. so it is 50%. It is so provided that here you see that actually this grandparent who is deceased here or who has died is was having Huntington disease. Now this female, since Huntington disease is an autosomal dominant condition, we are thinking that the probability, since autosomal dominant, provided that since it's autosomal dominant, if you draw the pedigree of Huntington disease, we are saying that what if you associate a man who is heterozygous with Huntington disease and a woman who is not affected with Huntington disease, you are going to have children, and the career status of the children is that the risk of one child to be carrier is going to be half. Is it clear? The probability for you to be a carrier is going to be half. Is it clear? And you need to know that, so that's the probability for you to be a carrier in Huntington disease. And when you're a carrier with autosomal dominant disease, you must express the disease, except there is a problem with the variation and penetrance, as you have already seen in the previous tutorial. Now, since this patient has not yet expressed Huntington disease by the age of 30 years, you cannot say that she does not have Huntington disease. She still have that probability of half for her to have Huntington disease. Is it clear? Now, the next one is age of it. So the child now of this woman, we have already seen again in the previous tutorial that what is relating the grandfather to the mother to his child is going to be a probability of half. But now, since both of them are having a first degree family issue, now from year to year, the relationship between the grandfather and the grandfather and the grandson is going to be a second degree family issue. Since this is a risk of 50%, with second degree family issue, what you just do is that you multiply this risk by half. Is it clear? So you multiply this risk by half, and since the child say A, so it's 50% times half is going to give you 25%. Now in example 2, from example 2 to example 4, now you have now a modification of the risk based on certain calculation that have been given by certain scores and certain theorems for Huntington disease. Now it says that when your age increases, that is an age of 60 years, it means that the probability now for you to have a pathogenic allele is extremely small. Is it clear? The probability for you to have a pathogenic allele is going to be extremely small if you have an age of 60 years and you have not yet developed the disease. Is it clear? Except they still that probability for you to have the pathogenic allele, because Huntington disease is an autosomal dominant disease and it may exist with different variations. Is it clear? It means that this patient here, this grandfather may have Huntington disease, but his child may not have Huntington disease because she expresses the disease in a smaller or milder degree, and she may not even express the degrees depending on the penetrance and the variation. And you see the probability for you to have the disease here at the age of 40 years is 5%. Is it clear? The next one is here. So this is still another one. So at the age of 70 years, the risk is 6%, and here in this population, at the age of 40 years, the risk is 2%. Here, at age of 30 years, the risk is 50%, and at age of 40 years, the risk is going to be 17% based on different calculations. So now this is example 5. So example 5, now this is how you do a transmission for autosomal dominant disease. As I was explaining, I'm saying that usually autosomal dominant disease are transmitted. This is an example of both parents affected with autosomal dominant disease. I've said that usually autosomal dominant disease are present. You have an autosomal dominant disease usually in a heterozygous patient. Is it clear? You don't usually have autosomal dominant disease in homozygous, because homozygous state usually is lethal to autosomal diseases. When you have an autosomal dominant disease and it is homozygous, usually the patient, the children die. Is it clear? So we are going to have this. If they are heterozygous, then one child among them is not going to be affected, and these all three children are going to be affected. So the probability for you to be a carrier is that you must be affected first, and you are going to be a carrier too. So these are the three people who are going to be affected. So it's going to be 2 in 3 who are affected are going to be carrier. So for the probability for you to be a carrier in an autosomal dominant is that you must be affected first. That's the first point. And the second point is that you are carrier later. So the 3 are affected. So you have 2 in 3 are affected. So it means that what? The probability for you to be a carrier with the autosomal dominant disease is 2/3. Now for the probability for you to be having to be a homozygous affected, it means that what? You must be affected first. Is it clear? You must be affected first. So those are the 3 who are affected, and then there is only 1 in 3 who is affected. Is it clear? So 1 in 3 who is affected. So it means that 1/3 are the people who are affected in homozygous. So that is how to calculate probability. So I've said that in order for you to calculate probability here, so it is here you are, when you are heterozygous, you must be affected. So the probability for you to be heterozygous and affected means that what? The people who are affected is that there are 3 in numbers. You have this is autosomal dominant disease. This patient, and this patient are going to be affected because it is an autosomal dominant disease. Is it clear? Now, if the probability now for you to be a carrier, it means that you are heterozygous. Since 3 of them are affected, how many in 3 of them are going to be heterozygous? Is 2. So the probability for you to be a carrier and affected is going to be 2 in 3. That is 2/3. Is it clear? So that's a simple method for you to calculate. Now the probability for you to be homozygous and affected, you need to know that the homozygous are first affected. How many people are affected? We have 1, 2, and 3. Is it clear? So, and then how many in these 3 people are affected? We have 1 in 3 people are affected. Is it clear? So it's going to be 1/3. The probability for you to be homozygous and affected. Now the probability for you to be unaffected, you need to know that what? How many people, for the probability for you to be unaffected, is it clear? So is you need to know that in how many, so the how many children, how many are going to be affected? We have only 1 in 4 children is going to be unaffected. Is it clear? Now there is another method if you want to calculate now heterozygous affected and homozygous affected. There is another method again to calculate heterozygous and homozygous affected. Let me just explain, but this is going to be using more of mathematics than analysis. Is it clear? So if you want to calculate the probability of heterozygous affected, you first calculate the probability for you to be affected. Is it clear? What is the probability for the children of this relationship to be affected? So the number of children that are going to be coming from the relation, let's say that the number of children is going to be 4, 1, 2, 3, and 4. Is it clear? For the probability for them to be affected, since it's an autosomal dominant disease, you need to know that what? All these 3 children are going to be affected in the 4 children. So it means that for the probability for you to be affected, the children to be affected is 3/4. Is it clear? Are you understanding? So the probability for the children to be affected is going to be 3 in 4. 1, 2, 3/4. Is it clear? So that is the probability for the children to be affected. Is it clear? Now the next thing is that we have again the probability, since you are talking about the heterozygous and affected, it means that what? You first have the probability of the affected and you have the probability for you to be heterozygous. So here, what is the probability for them to be carriers or heterozygous? It is 2 in 4. So it is 2 in 4 or half, so 2/4. So now the probability for you to be heterozygous and the probability for you to be affected is 3/4 times 2/4. Is it clear? 2 divided by 4. It is 3/4 times 2 all over 4. So when you do 3 times 2, it gives 6. And divided by 4 times 4, is it clear? So when you calculate like that, you realize that is that you are going to have 2/3 as your answer. Is it clear? So those are the different methods. So those are the two methods that you can use in order to calculate this case. So we continue with the next case now. We have example 6. So example 6. So in example 6 now, we say that what? We say reduced penetration also modify simple autosomal dominance risk. I've always explained that. So in this example 6, they are just telling you that what? This father here has the disease, and then the son of the father is going to also have the disease, but the other family member in the autosomal dominant group or the autosomal dominant disease are not having the disease. Why? It's because of the penetrance. It means the penetrance is just telling you that what? There are certain population with autosomal dominant disease or even with autosomal recessive disease that are not going to express the disorder. Is it clear? So there are certain population inside autosomal dominant disease or autosomal recessive disease that are not going to express the disorder. That is the penetrance. So there are certain diseases like A and B. The risk of having inherited is going to be 50%, but now the risk of developing a disorder is 40%, and then the chance of carrying the genes in the remaining unaffected is going to be 16%. So when you are unaffected and you are carrying the gene with the penetrance, so it's going to be 60%. And then in C now, they are telling you that the risk is that the risk of developing disorder is this based on the penetrance and all that. So now these are the different autosomal dominant disease and their risk of transmission based now on particular calculations. Neurofibromatosis, the complication that you have learning disability. It can be mild, moderate to severe. You have malignancy, you have scoliosis, and each of them mild, so each of them have their risk of transmission. So neurofibromatosis with learning disability transmitted is 30%, moderate to severe is 3%, malignancy is 5%, scoliosis is 10%. Is it clear? It means that different autosomal dominant disease have different symptoms. So they have different variants. This is actually the variation. So in certain people, you may have mild, moderate, malignancy, mild, moderate learning disability, malignancy, and scoliosis. Now in other people, so you may have just mild learning disability. That's the only thing. So you see that this is the variation of the disease based on the different symptoms, and that is called pleiotropy. And those symptoms are actually symptoms. Pleiotropy means that what you have a genetic disorder with symptoms with physical signs and symptoms which are actually diverging. They are not similar. Now, tuberous sclerosis. So what is tuberous sclerosis? You have in tuberous sclerosis, the complication, you have epilepsy, you have learning disability, mild to moderate to severe. You have myotonic dystrophy, severe congenital onset with maternal transmitted. You have Waardenburg syndrome, deafness. All of them have their particular risk of transmission. So now let's visualize example 7. So example 7, we continue now with autosomal recessive disorders. Now autosomal recessive disorder, let's say that you have one child in the family that is going to be affected. It means that when with autosomal recessive disorder, when one child in the family is affected, it means that the parents must be carrier. So the parents are unaffected, but they have been carrying the gene. Is it clear? So that's the point that I want to make. The parents are unaffected, but they have been carrying the gene. So the probability for you to transmit, for you to be affected is 1, because you are seeing the people who are affected. Immediately you are affected, immediately you express the disease. So when you have a patient that expresses the disease, just know that the probability for him to have the gene in him is 1. So there is no need for you to do again genotype for a sickle cell patient when you already have sickle cell disease with a hemoglobin electrophoresis. You can only do a karyotyping in order to visualize if there is any previous genetic disorder that can predispose the patient again to have another form of chromosomal abnormality. Is it clear? But you cannot actually say that you are going to do again another genetic disorder in order to prove a disease that you already have in the clinical aspect. So now let's say that the next one, so this next one here is the probability, since this other child, this other girl here is not having the disorder, so the probability for her to be a carrier is 2/3, because in autosomal recessive now, the way to understand is that what is that 3 children from that family are not going to be affected, and 2 of those children are going to be carriers. So 2/3 of them are going to be transmitting the allele. Is it clear? And then in order for you to continue, since this generation and this generation is separated by half, you multiply just half, so you are going to have 1/3 is going to be here, and here from here to here, since immediately a parent is affected with an autosomal recessive disease, all his children are going to have the pathologic allele. Is it clear? So that's why from here to here is going to be 1. Is it clear? Now these other ones here, it is unlikely. So separating here, so since the brother, so since this is a sister who is already a carrier, the degree relationship between the sister and the brother is going to be half. That's why the separation, as we have already seen in the last tutorial, that's why the separation here we have half. Now separating this brother and this other one is going to be half. So that's why we put 1/4, and separating this and this is going to be 1. It's going to also be half. When you multiply, give 1/8. Is it clear? Now, for example, this is a risk of transmitting, so this is the risk for having an offspring who is affected with cystic fibrosis. So an example of a case of a risk of having an offspring affected by cystic fibrosis. So now, let's understand it quite well. So in this example with the risk of having cystic fibrosis, actually they are saying that what if there is already one child in the family, immediately you have an autosomal recessive disease where one child in the family is having a disease, it means that both parents must be carriers. Is it clear? So this child has cystic fibrosis. Is it clear? Since this child has cystic fibrosis, it means that the parents must be autosomal, must be carriers. Is it clear? And if the parents are carriers, it means that this other mother who is having another relationship here and she is consulting, she has a 2/3 probability, 2 in 3 cases, because all the 3 children, the 3 remaining children are not going to be affected, but 2 in 3 of them are going to be carriers. So she has a probability for her to be carrier is going to be 2/3. Now, if you want to find out the risk for the offspring to be affected, actually to find the risk of offspring to be affected, you are going to use the Hardy-Weinberg equilibrium principle. And the Hardy-Weinberg equilibrium principle says that what for you to have an offspring, so who is going to be affected, you multiply the risk for the mother to be affected to that of the risk of the father to be affected times the risk for transmitting that autosomal recessive disease. So that is the Hardy-Weinberg equilibrium principle formula. It is the risk of the mother to be carrier and the risk of the father to be carrier times the risk of the offspring, so times the risk of the autosomal recessive disorder to be transmitted to the offspring. Now the risk of the mother to be a carrier is going to be 2/3. Now the risk of the father to be a carrier in Europe, the probability for you to be a carrier of cystic fibrosis is said to be 1 in 22 people. So that's why that risk has been used for the father, since the father allele is unknown. And then now you multiply now times the risk of transmitting the autosomal recessive disease, that cystic fibrosis, to the child. It is 1/4. When you draw the Mendelian segregation method, you are going to see this going to be 1/4. So when you multiply all that, your answer is going to be 1 divided by 1 in 132. So that's the Hardy-Weinberg equilibrium principle. Now, you also need to know that what this diagram here is just showing that consanguinity is going to increase the risk for you to have consanguinity is going to increase the risk for you to have an autosomal recessive disorder. So you may never see the autosomal recessive disorder. You see one generation has passed, second generation has passed, third generation has passed. Since the third generation has done now consanguinity, you see that what the disorder now reappears into the place. Is it clear? So third generation has done consanguinity. That's why the disorder reappears. That's why in our context the consanguinity, so we can only accept this type of relations as from the fifth generation separation. It's not the fourth, the third, and all that. It's as from the fifth generation separation that we can accept a relationship to get married. Now, the next one here, you see that here this couple already has a child who is consanguineous. It means that since this couple has a child who is consanguineous, it means that both parents must since this couple have done consanguinity and one child is already affected, it means that both of the parents must be carriers. So now the separation between this person and this person is going to be half. Since this is already is a carrier, so the probability for him to have the pathologic allele is also going to be half since they are separated. Is it clear? Now the separation from this to this is going to be also half. So those are the risks. So now in Hardy-Weinberg equilibrium, for you to have a pathologic child, it's going to be half times 1/4. So 1 in 16. There's a high probability for 1 in 16 children that are going to have is going to have that disorder. Is going to have that autosomal recessive disorder in the family. So this is same principle. So example 10 just tell you that what you have a family that both of the sons are going to be affected. So it means that if both of the sons are affected, it means that the father and the mother must be carriers of that autosomal recessive disease. Is it clear? So you see that this disorder. So it means that the risk for the child to be affected, the father already is affected. It means that the probability for the child to have the allele is 1. There is nothing to say again. The father is affected. Since the father is affected, the probability for the child to be having that allele in himself is already 1. Now the probability of the mother to have that allele, since they are doing a consanguinity, the mother has come from a generation which is associated here. This father here is the sister of this person here. Is it clear? And the relationship is going to be half. It's a first degree family issue, and the gene relationship is going to be half. So and this person and this person, the gene relationship is also first degree family issue. The gene relationship is half. So you do half times half is going to be 1/4. So the Hardy-Weinberg principle says that it's going to be 1 year times 1/4, or times the risk of transmitting the disorder now in this child. Since this person already is autosomal dominant, and this person is with the risk we don't know yet. Is it clear? Since this person is autosomal dominant and this person here, the risk for transmitting is 1/4. From autosomal dominant to a person who can be a carrier, the risk of transmitting is half to generation. So the risk of transmitting to the affected child is going to be 1/8. So 1 in 8 of their children are going to be affected. So now example 11 and example 12 just speak about what is called locus heterogeneity and genetic heterogeneity. We have spoken about that in the initial chapters. In locus heterogeneity, it means that when there are multiple alleles at different locations, which is going to be encoding for one gene. Example, the gene of deafness, like in this case. So there are certain genes which are located on different chromosomes locations, which is going to express the single deafness. Is it clear? And there's also what is called genetic heterogeneity, which is that what there are multiple alleles on one particular location or one particular locus that expresses the same gene. So this heterogenesis can be explained here. Locus heterogeneity can be explained here. So this father and this mother are having an allele which is located on the same locus. Is it clear? They have alleles, or they have allele of deafness located on the same locus. So they are homozygous. So they have homogenic alleles. So now, since they have homogenic alleles, all the children are going to be affected. Immediately you have a homogenic allele, you have alleles which is allele which is encoding a particular gene on same location. You are going to express all that in your children. But if you have alleles on different locations, so you see that the father here is having allele, let's say on chromosome 1, the mother is having the allele of deafness, let's say on chromosome 3. The children, the child is going to have allele on chromosome 1 and chromosome 3. This child is going to have allele on chromosome 1 and chromosome 3, and this same to this child. But you see that all the children here are unaffected. Why? Because they are not having alleles at the level of the same locus or location. Is it clear? It is only when you have allele at the same location that you can express the disease. But if you have allele at different locations, you are not going to be expressing the disease. That is called heterogeneity. Is it clear? Locus and genetic heterogeneity. Now, the next one is example 13. So in example 13, they're just speaking about the transmission of diseases from based on the zygosity. Now, if you have monozygous twins, because this is dizygous twins, you consider dizygous twins just like brothers and sisters. Is it clear? So you just consider dizygous twins as brothers and sisters, and you consider monozygous twins as the same person. So when you have monozygous twin, consider the same person. Dizygous twin, consider as brothers and sisters. Dizygous twin, you just have two arrows like that. While monozygous twins, you are going to have a line in the middle of the two lines, like this, in the line in the middle. But this one is dizygous twin. Also, you have probability for you to be affected and unaffected based on dizygous and zygosity here, because of the calculations that has been done by certain research studies. The next one is X-linked disorders. Usually, we have already said that X-linked disorders are transmitted to male patients. Male patients are going to make all their female to be carriers, and then the female carriers are going to transmit their disease to the male. So those are the different theorems that you should know in the pedigree of an X-linked recessive disorder. So let's say that you have a patient who is having a disease. It means that the brother is going to have the sister is going to have the probability for her to be carrying an allele of the disease is going to be half. Now, if immediately a child is having in X-linked disorder, immediately one male child is having the disease in X-linked disorder, the mother must be a carrier. That is why she is called an obligate carrier. Is it clear? Also, immediately the one child in a family is an obligate carrier. One girl, not any child, one girl in the family is an obligate carrier. It means that the father must have had the disease in the previous generation. Is it clear? So that is how you visualize now the diseases here in X-linked recessive disorders. So now in example 17, we have this case with conditional probabilities here. So when you have a mother which has a probability of 1/3 to be a carrier, so there's a probability for her to be having an X-linked disease. So the probability for her to have an X-linked disease is 1/3. So the children, you see that this relationship here is going to be 1/6. So it's 1/3 times half is going to be 1/6. Now for this probability here, which is in order to calculate the probability of the mother to be unaffected, So you can use also the number of children she had in order for you to calculate the probability of the mother to be unaffected. You use the number of children she had, and then you also calculate. But this is it's an in-depth calculation that is done on the tutorials on genetics further. So now the next one, now you have isolated cases. So in isolated cases, so you still have this, so you have the probability for you to transmit the disease. Based on that, I'm not going to speak about that more in these tutorials. So this is an isolated case where every time you have a patient, you can derive the other probabilities on the pedigree, is it clear, for you to have the different disorders. So possible causes of sporadic cases. So what are the possible causes of sporadic cases? You have autoimmune B. Sporadic cases mean that it occurs time by time. There is no particular pattern. So when they say sporadic inheritance, it means that there is no pattern. You cannot actually predict a sporadic a case, because it is occurring time by time. And now these are the causes of sporadic cases. It can be autosomal dominant disorder, autosomal recessive disorder, X-linked recessive chromosomal disorder, polygenic or multifactorial disorder, and non-genetic disorder. So from here we are finished with this tutorial on the risk of Mendelian disorder. Please don't forget to like and subscribe for our channel. Thanks very much.